Hello, everyone. Welcome back to our next session of the NCLEX review. So if you are new here, welcome. And this is going to be our 28, I believe, of the 90-day series preparing you for the NCLEX. And again, we're doing this for free. So we really want you to be prepared for the examination and make sure that you're going to sign up for the dynamic NCLEX review course that we have at Stancoast NCLEX Coaching at www.stancoastnclexcoaching.com, and also make sure that you're going to be able to engage with our insightful lectures over about 3,000 NCLEX questions with interactive methods will be presented to you guys. And of course, we have a 10-hour animated video that will also assist you with your learning in order for you to boost your confidence. We do have our on-demand video library and also mock exams that you can access for about 6 months. And that includes the 200 NGN test questions. So you can do this at your own pace. And our platform is user-friendly. And we're also going to be offering the different topics and also 2,000 NCLEX questions with our daily live lectures here at YouTube. And make sure that you hit on the like, subscribe, and turn on your notifications for our latest updates. Now, if you need some more information, kindly visit the link below, and your feedback really matters to us. So share your thoughts and all your questions, your comments, and we'll be happy to assist you. Now, today we will be moving forward with our actually not lecture, but we're going to proceed with part 2 of our Q&A. NCLEX questions. And for those who are in the room, welcome, welcome, welcome. We have Ms. Ubay, Alice, and Mushahid. Welcome. And the rest of the class members, welcome to the live lecture. All right. So let's get started with our discussion today. So our first question states right here. A nurse at a healthcare provider's office is explaining details for patients scheduled for the pulmonary function tests, or known as the PFTs. And the nurse should provide the following guidance. Again, let me reread the test question. A nurse at a healthcare provider's office is explaining details to a patient scheduled for pulmonary function tests, or known as the PFTs. The nurse should provide the following guidance. A, avoid using your inhalers for 6 hours after the test is completed. B, refrain from smoking any tobacco products for 6 to 8 hours before the test. Or C, during the test, you will be instructed to perform breath holding technique. And D, part of the test will involve checking the blood flow to your hand. All right, guys, I really want you to participate here and make sure to put in your answers in the comment section or the chat box, so we'll be able to see who's really engaging with our discussion. Again, our question here is asking about what guidance should the nurse provide to the patient who is scheduled to undergo the pulmonary function test. Is it A, avoid using the inhalers for 6 hours after the test is completed? Or is it B, refrain from smoking any tobacco products for 6 to 8 hours before the test? Or C, during the test, you will be instructed to perform a breath holding technique. And lastly, D, part of the test will involve checking the blood flow to your hand. Hello, hello. I hope that you're reading through the test question here and also the options. What would be your answer here, guys? Alice answered letter B. Okay, that is refrain from smoking any tobacco products for 6 to 8 hours before the test. We also have Badil Titoson answering B as well. Same thing with Linley. Is that how you say your name? Yes, that is the correct answer. Let me activate my pen. Letter B is the correct answer. Well, what is the reason why we should tell the patient to refrain from tobacco smoking or cigarette smoking at least 6 to 8 hours before the test? Well, the tobacco smoke itself can cause temporary alteration in the lung function. Okay, it can irritate the airways. That's the main reason. Okay, and when it happens, when the cigarette smoke is irritating the airway, it can also increase the mucus production and will eventually cause constriction of the bronchial tubes. Let me write down the rationale here. It can increase mucus. Okay, but before the mucus is increased, it can also lead to irritation of the airway. The smoke itself will do that. Okay. And we also have the constriction, or I'll just put here bronchoconstriction. Bronchoconstriction. So it would be a whole lot better if you were going to explain this to your patient in a very simple way. Make it very understandable for them when you are giving the caution why they should stop smoking eventually, not just for the testing, but as part of their lifestyle modification. You teach them that the cigarette smoke itself can irritate the airway, especially if they have a pre-existing lung disease. It can also increase the mucus production. That's why you're going to often hear him coughing, and also will end up with the bronchospasm because of the irritation and the mucus production. Okay. B, but I'm not sure if the patient is already on it. Yeah, this is a instruction that is kind of like a generic. It doesn't really give us an idea if the patient has a history of cigarette smoking. But to give a better picture, in order to give some more information to the patient, we'll just let them know either you're a smoker or not. You could be a secondhand smoker, then definitely you need to avoid yourself from exposing, let's say, a spouse or a boyfriend or a girlfriend at home. You need to not to be exposed from any of these irritants, especially the cigarette smoke. Okay, that's why it's kind of like a generic kind of a precaution or a teaching before they undergo the PFT. Okay, now what happens if they're going to end up getting exposed to the cigarette smoke or the tobacco smoke? Well, what's going to happen to the result here with a pulmonary function test? This will lead to inaccurate PFTs, and this will give a false positive reading, saying that the lungs is really inefficient and there is a decreased or increased capacity, especially for those patients that may have the emphysema. Okay, and so with the withholding or having them to stop smoking at least within that duration, 6 to 8 hours, that's very specific. Okay, so this will ensure that their lung function is not artificially impaired, and also it can give a better idea of how the PFT can get a better, I should say, reliable measurement. Okay, now if you had answered letter A, avoid using inhalers for 6 hours after the test is completed. Now, I really want you to pay attention of how the sentence is constructed. Avoid using your inhalers for 6 hours after the test. Well, the word here that makes it kind of like a huge factor that it's going to make it a wrong option. It's because of the 6 hours after the test. It doesn't really matter. I mean, the patient should resume taking their inhalers after the procedure. Yeah, the test is already done, so it should not really affect the readings, right? Again, for those who just came in, welcome to the class. Can you tell us where you're coming from, what state or country? So we'll let you know how far we have reached with this review series, okay? All right, let's move on to the option C. What is this? During the test, you will be instructed to perform breath holding technique. Are we supposed to tell them that they should do a breath holding? So basically, the breath holding is pertaining to the Valsalva maneuver. Bearing down. That's breath holding. Valsalva maneuver. It could be a very strong breath holding, just like when a person poops, but the holding itself of the breath is already considered as a Valsalva's maneuver. And so this is not part of the testing, and so we're going to eliminate letter C. There's no breath holding involved. Okay. Now, instead of doing the breath holding, what the patient will do when they're going to undergo the pulmonary function test. Hi, Roberta, welcome from Missouri. And Orji Judy from Nigeria, welcome. Now, with the Valsalva's maneuver, no, not the Valsalva's, no, I'm getting distracted. In the pulmonary function test, rather, the patient is instructed into breathing into a mouthpiece, okay? So they're gonna be doing that while the technician will be measuring all those values. It will measure the lung volume, we have the capacity, the flow rates, and also the gas exchange. This will be measured simultaneously. Now, the Valsalva's maneuver, though, which is really not part of the PFT, this is going to be useful in some procedures. Let's say whenever there is collection of the arterial blood gas, remember? The Valsalva's maneuver will be instructed to the patient. I don't know if you noticed this, but the Valsalva is actually a good instruction in order to prevent air embolism. Okay, when you are puncturing the arterial site, yeah, you have to instruct them to hold their breath momentarily in order to prevent entry of possible air embolism. Yeah, we have Pocholo Dumaya from Canada, and we have Suzette. Welcome, welcome. We have a new batch of attendees here. Very good. Now, how about letter D? Part of the test will involve checking the blood flow to your hand. And this is something that we have talked about yesterday, checking on both the ulnar and the radial arteries in order to check for the integrity of the collateral circulation. So before, the nurse will be drawing blood into those arterial sites, or the radial site, I should say. They should make sure that the integrity of the collateral circulation is good. I'm telling you that it should show us that there is a good blood flow when you're occluding the ulnar and the radial artery. And you're going to have to withdraw one occlusion and check for the collateral circulation. If there is coloration, a pinkish coloration into the hand or the distal portion of the hand, then that's a good sign. If you're going to partially, or if you're going to remove the occlusion on the ulnar and then you're going to occlude the radial after, then that means that there is a good circulation into that peripheral or distal site. Okay. So again, the Valsalva's maneuver is not really part of the pulmonary function test. However, this can be useful when you are instructing the patient when you're about to draw the arterial blood gas in the radial artery to prevent air embolism. Okay, this is probably not emphasized so much in the ABG, but I'm just going to include this at the moment. Now, we're going to have to really delve in so much more of some procedures today. Now, the next question, number 2. A nurse is preparing a patient scheduled for a thoracentesis. Which of the following items should be available in the patient's room? Select all that apply. Is it A, suture removal kit? Or is it B, incentive spirometer? Or is it C, pulse oximeter? Or D, sterile dressing? Or E, oxygen setup? All right, rereading the question. A nurse is preparing a patient scheduled for a thoracentesis. Which of the following items should be available in the patient's room? Select all that apply. Is it A, suture removal kit? B, incentive spirometer? C, pulse oximeter? D, sterile dressing? And E, oxygen setup. What's your answer here, guys? This is a select all that apply. And you will see some more of the SATA today. Hello. Anyway, I'll wait for your answers before I'll move on. Obey answered letters C, D, and E. Pulse oximeter, sterile dressing, oxygen setup. What about the others? And remember, guys, that thoracentesis can be done. It could be under radiology or ultrasound guided. And sometimes it can be done in the patient's room, okay? Provided that the room setup is quite organized and we have all the equipment available just in case. Lindley answered C and D, and Stefania answered A. Okay, we have Badiel answered D, E, C. Okay, let's find out, guys. So, and Joyce answered C, E. So let's find out here. Well, I will reveal first the correct answer. So this will give us a better idea on what really is the accurate answer or answers for this question. And so the correct selections for this item, we have Suzette answering letter C. Guys, please don't forget that when you are answering a SATA question, it will be needing at least more than one option, okay? Don't waste the points. If you are sure with the other options, then don't omit that answer. Or don't overdo with your selections, because this will be deducted against the correct answers. So you got to be careful, narrow down your options to the most correct or suitable answers. Shola answered C and E. Set answered C. All right. Now, we have the following correct answer. So that would be letter C, pulse oximeter. We have the D, sterile dressing, and E, oxygen setup. Well, why do we need to make sure that we have the pulse oximeter? That is very easy to have in the patient's room. It could be a wall-mounted pulse oximetry, or it could be one of those portable pulse oximetry that you can place in your pocket. But the use of the pulse oximetry is to make sure that we are able to monitor the patient's oxygen saturation levels continuously, not just a random spot check. But we want to make sure that we are doing this, misspelled already, continuously. So we want to make sure, NCLEX in 5 days. HB, I'm wishing you all the best for your NCLEX exam, or NCLEX, I should say. Yeah. All right. So we want to make sure that our patient's saturation levels is consistent, that if in case it drops, we will be able to respond to that emergent situation right away. Make sure that you have that device. Now, what about the sterile dressing? It doesn't really mean that you have to have the bulky dressing like the 4x4 gauze or ABD pads. We don't need those big dressing. What we're only needing is just maybe a piece of like a 1x1 or 2x2, or it could be there's just a regular Band-Aid. Okay, that's already considered a dressing. And the reason that we need to make sure this is included, it's because the site has already been punctured, and this can be a port for the microorganisms to go in and could potentially cause an infection into the site. All right, so we want to make sure that this is covered up until the site heals. And of course, we're going to have to teach the patient to keep the Band-Aid or dressing on for that duration. Yeah, of course. Yeah, we want to make sure that this is going to be protected. Now, for the oxygen setup, why do we need to have that oxygen setup? Well, this is going to be needed if in case the patient will be developing significant respiratory distress, or let's say hypoxia. But you know what, guys? For those patients that will be needing thoracentesis, they will be getting this procedure because they probably had a pre-existing shortness of breath. Okay, that's the reason that the patient will be having this fluid drained in order to remove the excess fluid from the pleural space in order that their breathing will be improved. And some of these patients probably are already using the oxygen. Okay, so they probably now has used the they probably had been wearing the O2 rather with a nasal cannula while they are doing or while they are receiving the diagnostic test or the procedure. So make sure that this is available. Okay, and most often if they're going to have this procedure in their room, then you can just have the setup ready, the nasal cannula tubing maybe, or maybe a simple mask or non-rebreather just in case that the patient will go into a severe hypoxemia just in case. Yeah, you got to be ready for the possible complications that may arise. And like I've said yesterday, with the thoracentesis, it could potentially puncture the lung tissue. It could cause hemorrhage, might end up with a hemothorax, or could end up with a pneumothorax. Okay. Now, all right. So we have a comment here from Mary. When there is dislodgement, I'm not quite sure what you're pertaining, so kindly clarify, please. All right. Thank you. And we'll talk about the suture removal kit. This is not necessary. That's why we're going to get rid of that. There is no need to do removal of the suture when a patient goes for a thoracentesis, okay? Because the procedure itself only involves the insertion of a very small needle or a catheter, and sutures are not going to be involved here. Now, incentive spirometer, it's basically with that device, right, that you have seen, that kind of like clear plastic material that has a mouthpiece, the different balls inside that would elevate when the patient inhales. That's the incentive spirometer. But this is not going to be required when the patient goes for a thoracentesis, okay? This is only required when you are encouraging the patient to take deep breaths in order to prevent atelectasis, especially if they just came out of, let's say, a surgical procedure or they are post-op, then they definitely need to engage themselves more often with the incentive spirometer as much as they can, let's say every 2 to 4 hours, in order to prevent lung collapse after the surgical procedure, okay? Now, this is a very simple test question, but this can easily fool you as well if you are gonna miss out on the key elements. So make sure that you recall the procedure. Make sure that you can also recall the potential complications when the thoracentesis is conducted, okay? You have to be ready about the hemothorax, could be the pneumothorax, possibly the hypoxemia. So you got to make sure that you will have the equipment available, such as the oxygen setup. We also have the sterile dressing, the pulse oximeter. Okay, that will be used after surgery as a recovery process for the lungs. Yes, this incentive spirometer is intended to help out the patient, make sure that they will be able to have that kind of goal, because there will be set parameters. You can adjust the amount of mLs for the patient to achieve. Okay, let's say for the first day, we want the patient to achieve 1 liter of inhalation, right? So maybe the following day, we're gonna have to bump the level of the goal. So day by day, this will help out the patient to achieve those realistic goals, okay? And that is the importance of teaching them how to use the incentive spirometer. But again, this is not really intended for the thoracentesis, okay? I'm just telling you some tidbits of the implications of the other equipment. Now let's talk about question number 3 here. A nurse is getting ready to care for a patient after the insertion of a chest tube. Which supplies should be in the patient's room? Select all that apply. Question number 3 says, a nurse is getting ready to care for a patient after the insertion of a chest tube. Which supplies should be in the patient's room? Select all that apply. Is it A, occlusive dressing, B, urinary catheter, C, hemostat clamps, D, sterile water, E, oxygen. Okay, we got a choices here. Occlusive dressing, urinary catheter, hemostat clamps, sterile water, oxygen. 4G answered B and D. That is urinary catheter and sterile water. Guys, please don't get confused. We are talking about the insertion of a chest tube, the respiratory system. Okay? So I really want you to narrow down your options. Recall of what this procedure is all about. Okay? We have ACD from Sil. Stefania answered ACD. Lindley answered ACDE. Shoni DE. They ACDE, and Mary answered DE. Okay. So the correct answers for this situation or this scenario, this is a select all that apply, guys. We're talking about chest tube that has been inserted. Okay, so we are actually, the situation here says a nurse is getting ready to care for a patient after the insertion of a chest tube. So what would be those needed equipment in the room? Okay, so one of those is going to be A, occlusive dressing. That is very important, guys. All right, we'll just pick one by one right now. What's the use of the occlusive dressing? Of course, you're going to have to cover that puncture site, the insertion site, because that's going to allow microorganism to enter into the pleura if we're not being careful. And it will prevent the air from entering the pleural space. So the reason why we want to make sure that we have the occlusive dressing is to prevent the atmospheric air to enter the pleura or the pleural space. That's the reason. Because if we're allowing the air from the atmosphere to go inside the pleural space, that is what we call as pneumothorax. We don't want that. Okay? Entry of air into the pleural space from the outside can lead to pneumothorax. Yeah, that is the thought about that. There is going to be the application of the dressing right after the insertion. That's correct. But you are the nurse that will be getting ready to take care of the patient. You always have to be ready with the extra supply. Just in case something happens, when there is an accidental pull of the chest tube, then you should have this occlusive dressing readily available in the patient's room. Okay? So make sure that you have this readily available. I'm not talking that this situation or this option doesn't state that you're going to have to be applying this dressing right there and then. No, the thought of this selection is that we are going to make sure we have an available supply just in case something happens with this patient, if there is an accidental removal of the chest tube. Okay. All right. Now, what else? All right, we have the hemostat clamps. That is another equipment that needs to be readily available in the patient's room. Okay, make sure that these equipment or devices will be placed in a plastic bag or maybe like a Ziploc bag that could be easily seen by the nurses. Make sure that this is going to be easily visible in the patient's room, just to make sure we have it readily available if something happens. Okay, accidental removal is one of those. So the reason that we need to keep the hemostat clamps available is to, if there is possibly a need for us to change the drainage system, especially during the first 2 days. If there is, let's say, increasing drainage, or maybe because the case of the patient involved hemothorax. So there's a whole lot of blood, or it could be a lot of pleural fluid that has accumulated in the patient's chest before the insertion, then we're going to have to facilitate the drainage, right? And most often, if there is an increased drainage of those fluids, let's say blood, or it could be the pleural fluid or pus, we want to make sure that we have that hemostat clamp and make sure that we have the another setup available, like the pleur evac, to make sure that we can facilitate an immediate switch from the old appliance to the new one. Okay, we want to make sure that this is done in a very what do you call this, smooth fashion, in order for us to prevent some complications along the way. Okay, and the reason that we want to make sure that we have the hemostat clamp ready is to do that clamping, short period of clamping, in order to prevent the air from entering the pleural space, which could potentially cause pneumothorax. Again, the use of the clamp should be so minimal because we don't want to cause tension pneumothorax as well. So you gotta keep that in mind. Now, what about the other equipment here? You gotta make sure that there is that sterile water, that is a fresh bottle of sterile water, meaning it's not open, it's sealed. Okay, and the reason that we need to have that sterile water, okay, so it's a pre-filled bottle, it's not used, it's not punctured, and make sure that it's readily available together with a hemostat and the occlusive dressing. And this is something that will be useful in case there is an accidental removal of the chest tube. Okay, and also if there is accidental disconnection of the tubing from the appliance itself, then what we can do is we're going to have to dip the distal end of the tube into the sterile water bottle in order to prevent the entry of the atmospheric air into the pleural space. Okay, so that is the reason why we need to have that sterile water in the room. It's not really there's also a need for us to have a standby sterile water, because if in case the pleur evac system is connected to the suction, then you have to keep an eye as well into the water level to make sure that it's not going to be dried. Okay, so make sure that if this is a wet system, you got to make sure that you're going to look into the suction chamber to make sure that it's not dried up. So at least check the chamber every 2 hours. So make sure that it's not dried up. Okay, but again, the sterile water that we're talking about here is intended just for the possibility that there will be accidental dislodgement of the tubing. Now, what about letter E? Do you think that E is one of those? Yeah? Is letter E included? Yes, of course. Letter E is another correct answer. And this is going to be needed if in case there is a sudden drop off the oxygen saturation. So make sure you have that O2 setup as well. And so we're going to be eliminating the urinary catheter. It's not going to be useful in this scenario. There's no need for us to place in a urinary catheter. There's no such indication telling us that the patient is having difficulty urinating or to do accurate intake and output measurement. We don't have that need. Okay, so again, our focus here, you're going to make sure that if you are dealing with a procedure that is all about respiratory procedure, let's say thoracentesis, chest tube placement, then our care here will mostly focus regarding the lung function, okay, and the possible complications that may occur. So that would be one of the test-taking strategies here. So we're going to have to eliminate those choices that are not associated with the procedure, okay? It's not related to this one, okay? Well, very good job for those who got the correct answers. We have occlusive dressing, hemostat, sterile water, and oxygen. Very good. Now let's move on to the next question here. Question number 4. A nurse is educating a client with COPD who has been prescribed albuterol. Which statement by the client shows they understand the teaching? Okay. A nurse is educating a client with COPD who has been prescribed albuterol. Which statement by the client shows they understand the teaching? Is it A, this medication may raise my blood sugar levels? B, this medication may lower my immune response? Or is it C, I might experience an increase in my heart rate while using this medication? Or D, I could develop mouth sores while using this medication? We got some good answers here. C, yeah, I'm seeing a lot of C's here. Very good. So talking about the medication that it's involved in this case, the patient has COPD. Albuterol. Yeah, that's a bronchodilator, right? And remember about the bronchodilator, it's classified as a beta-2 adrenergic agonist. And this would be probably helpful to you guys to remember albuterol. This is what we call as SABA, short-acting beta adrenergic. Okay, don't forget that. Okay, beta adrenergic agonist or beta-2 adrenergic agonist. For example, the albuterol, this is what we call as the short-acting beta adrenergic agonist. It has a rapid therapeutic effect to cause a bronchodilation. The airways, the terminal bronchioles, the bigger airways, it will cause that dilation of those passages. And so remember about the beta-2 adrenergic agonist. The receptor sites for these B2 receptor sites are actually going to be found in the smooth muscles of the lungs. Smooth muscles of the lungs. So we can find those receptors in the smooth muscles. And aside from that, the beta-2 receptors are also present in the heart muscle. Okay. And so this can lead to the tachycardia. So it's not just isolated muscles. Geez, let me rewrite that. Not measles, muscles. Okay. All right, heart muscle. So again, it can cause that side effect, tachycardia, which is expected. Nothing to really worry about that. But if the patient will be abusing the albuterol, in most cases, I see a lot of patients doing this, that they will be inhaling the albuterol more than the desired frequency. Instead of taking it every 4 hours as needed, they're abusing it, let's say every 2 to 3 hours. And yeah, it's not going to work. It will have that paradoxical effect if they're overdoing it. Aside from having the arrhythmias, they're going to end up with the paradoxical effect. They're going to end up with bronchospasm. Okay, take note of that, guys. If the patient will exceed the use of the bronchodilator albuterol, it will have a paradoxical effect. Please take note of that. Now, and so our answer here is the letter C. I might experience an increase in my heart rate while using this medication. Now, why not letter A? This medication may raise my blood sugar levels. Why is letter A not a correct answer? Well, this is not really a relevant rationale for the teaching. It doesn't show the therapeutic or the side effect of the medication. Okay, so actually the albuterol will primarily affect the respiratory muscles or the bronchus or the bronchioles. It doesn't do a lot of the blood sugar elevation. Okay, so we are eliminating that. What about letter B? Yeah, that's correct, Badil. Letter B, this medication may lower my immune response. That is also incorrect because it's not an immunosuppressant agent. It is not a steroid. So we are eliminating letter B. If you had answered letter B, then this can pertain to the glucocorticoid. It could be the oral form of the glucocorticoid, prednisone. So this is not appropriate for this question. What about letter D? I could develop mouth sores while using this medication. Well, albuterol does not really going to lead to that side effect. However, this can be caused by those inhaled corticosteroid, okay? The mouth sores, and also like the fungal infection, like the yeast. Yes, this is not all about albuterol. So this is a side effect of the corticosteroid. Okay, that's not a side effect of albuterol at all. So our answer here is letter C. Okay, so again, our testing strategy here, guys, make sure that you recall what the albuterol does to the lungs. Okay, make sure that you remember its drug action primarily is to cause bronchodilation, and it may result to a side effect known as tachycardia because of the beta 2 receptors that are also common or found in the heart muscle. That's why there is that side effect. However, like I've said, if the patient is abusing the medication, using it as frequently, not following the doctor's order, then they're going to end up with the arrhythmias and they will end up with the paradoxical effect, bronchospasm. Now let's get moving to the next question here. Question number 5. After the patient had a chest tube and drainage placed, the nurse notices that the chest tube has accidentally been pulled out. What should the nurse do first? Yeah, this is quite a common scenario. So again, the question states, after the patient had a chest tube and drainage placed, the nurse notices that the chest tube has accidentally been pulled out. What should the nurse do first? Is it A, request a chest x-ray? Or is it B, cover the insertion site with sterile gauze? Or C, tape the insertion site? Or D, check the patient's breathing? Again, the choices are chest, request for a chest x-ray, B, cover the insertion site with sterile gauze, C, tape the insertion site, and D, check the patient's breathing. Wonderful. I'm seeing a lot of B's. Very good. Good job. That is the correct answer. This is the first nursing action. When you see that the chest tube has been pulled out from the patient's chest, you don't have to do vital signs first before you gonna cover the chest area, okay? You don't have to listen first the lung sounds before applying the dressing. Automatically do the covering right away, okay? And the reason for that, it's because it is a life-threatening scenario. We don't want the atmospheric air to go inside the pleural space. We don't want that. And so you immediately intervene. Make sure you do the covering using that sterile gauze into the insertion site. Don't waste your time in checking the blood pressure or listening the lung sounds. Please don't do that. No necessary assessments will be needed this time. You got to do your thing, guys. Make sure you cover the insertion site right away, okay? If you had answered letter A, request a chest x-ray, well, this is going to delay of treatment. You're actually causing harm to your patient if you are doing the requisition. You're not dealing that issue if you have opted to get this letter A. So you are harming the patient, even though we can do the chest x-ray after the dressing has been applied, but not necessarily as the first action, okay? This is not the immediate priority. We can always do the chest x-ray after the incident has been stabilized. We want to make sure that the air entry is prevented. Okay. What about letter C? Tape the insertion site. I've never heard of any nurse, or I don't know, maybe they did this in some scenarios, but yeah, I've never heard of a nursing intervention of taping the insertion site. It's not recommended as the first action. So we want to make sure that we have the sterile gauze to cover the insertion site in order to prevent, the entry of the atmospheric air. All right. Now, what about letter D? Check the patient's breathing. Yeah, you are delaying the treatment here, guys. You are delaying the intervention. You are harming the patient. You are wasting seconds here. It could be minutes listening to the lungs. So eliminate that, okay? It is important that we will be doing the auscultation after we have applied the dressing, but not necessarily the first step in this scenario. Okay, so make sure the dressing is applied first. Now, what would be your strategy here, guys, in order that this will be imprinted into your subconscious? Again, what you are supposed to do here is prioritize immediate action. So you have to select that intervention that will prevent the complication from occurring. Okay. Prevent complication. I'll just write CX for complication. You got to make sure that you have to address the life-threatening scenario first. Again, think about the patient's safety. All right. And also, in some cases, really, you have to really weigh in whether you're going to have to assess versus acting. Okay. Because it's not necessarily that we have to do the assessment on every scenario. No, that's not true. Assessment versus action is quite controversial. If you already have the information, if everything is already observable, let's say, yeah, the tube has already been dislodged, right? Yeah, you don't have to get more assessment findings. Hey, the tube is completely out. No. It's already out, so you don't have to investigate further. It's already dislodged, so make sure you act on that one. But in other scenarios, you probably have to do some assessments before you're going to have to implement. It is going to be a varied decision, okay? So you got to think about that. So it's not always doing assessment before acting, okay? So you have to prioritize what could possibly prevent a complication to occur. Now, we are going to have to also understand the procedure itself. We're going to make sure that we are eliminating those actions or interventions or assessment findings that will not address the immediate threat. And again, the immediate threat here is the accidental removal. We got to act on it as early as possible. All right. So I did say that the others are not supposed to be done. Yeah, we can do those other interventions, but they should not take priority before covering the insertion site. Okay. Now let's move on to the next question. Question number 6. A nurse is about to give the first dose of prednisone to a client with COPD. Which adverse effects should the nurse monitor for? Select all that apply. Again, the question states, a nurse is about to give the first dose of prednisone to a client with COPD. Which adverse effects should the nurse monitor for? Select all that apply. So we have our selections: A, low potassium levels; B, rapid heartbeat; C, retaining fluid or fluid retention; D, feeling nauseous; E, dark, sticky stools. This is a very basic pharmacology question, guys, regarding steroid therapy in a patient with a COPD. Okay, I'll wait. I need to see your responses first before I'll proceed. So which of the options here? You are supposed to answer more than one. Select all that apply, guys. Don't forget. Select all that apply. Mary answered only one. Letter C. Any more, Mary? There should be more than one. What about obey? You answered BD, rapid heartbeat and feeling nauseous. Anyone? Any more answers? Mary Moyo answered A. Stefania answered BD. And Virtuous Lady answered BCD. All right. So again, let's go back to the scenario. The patient has a COPD, right? And the patient is supposed to get the prednisone as the first dose. Okay, so you have to monitor the patient for the adverse effect. This is a common action that nurses usually will kind of neglect. It's the monitoring of the adverse effect. I'm telling you, yeah, it's common. Sometimes we get so busy with the other stuff that we forget to monitor about the drug effects in our patient. We probably would not be able to know up until the patient will complain about it, or if the problem becomes worse. And so you really have to do this adverse reaction monitoring. You have to keep asking them after the first dose. Make sure that you tell them, hey, can you let me know if in case you will feel these side effects? So in order for us to be aware in a timely manner, we really need to educate our patient about having them to report those side effects so they can participate in their care. They can be more proactive in their care. And that is the reason why education when we are administering the medication to the patient is very important, guys. Jazz Skills Kitchen answered E. Boss Babe, BCD. Raki, BCD. Okioma, is that how you say your name? ABD, Badiel, ABC. Mary, BCD. Linley, ACE. All right, let's go through the answers here. Well, the correct answers for this question, it's a SATA. It's A, low potassium levels. Also, we have retention of fluid or retaining fluid. Oh, and also we have letter E. Let me explain, guys, why there is going to be low potassium level. The reason that the patient will end up with hypokalemia, it is because the steroid itself can promote the potassium loss in the kidney. Okay, remember about that inverse relationship with the sodium and potassium and also the aldosterone. Remember about that? So sodium and potassium are enemies. Now, the steroid, which is basically going to cause sodium retention. Let me just simply explain this. I don't want to do a whole lot of medical jargons here because it's not going to be helpful, right? I usually would like to simplify things, and I hope that you're able to understand as well. And so sodium and steroids are best friends, right? The steroid can cause sodium retention in the renal tubules. Okay, that's what it can do. It can also lead to water retention. Now, why is the potassium being low this time? Why is it going to be that? Okay, and the reason because of the inverse relationship between the sodium and potassium. Once there is an elevation of the sodium because of possibly the aldosterone is elevated as well, this can cause the excretion of potassium ions in the kidney tubules. Okay, that is why our patient will have hypokalemia, increased excretion of potassium ions in the kidney tubules. That is why our patient will end up with hypokalemia. So this is a tip for you guys. Whenever your patient is going to be placed on any steroid medication, it could be IV, it could be a PO, think about those patients that they're going to end up with a hypokalemia, especially if the dose is given in a lengthy duration. okay? And there should be periodic checking of the electrolytes, especially the potassium, because when the potassium goes down, it can do a lot of bad things to the heart, also the muscles. It can definitely cause some hemodynamic impairment. So the heart rate will go up. If you have a patient that may have atrial fibrillation and with hypokalemia, not a good mix. And if your patient is taking digoxin with the Lasix probably, and plus they have heart failure, yeah, this patient will end up with digoxin toxicity. Okay. The ACE, yeah, Virtuous Lady answered ACE. Yeah, that's the correct selection of answers. Very good. Now, what about letter C? I think I already explained about the letter C. There will be retention of the water and also the sodium. And so the patient will end up with what? Weight gain. And probably the patient will tell you, hey, nurse, can you check my hands? Looks like my my fingers are kind of puffy looking, or I'm having some puffiness in my face, or there is now some puffiness in the periorbital area, or it could be some ankle edema. And this is what usually will happen to your patient if they are taking the steroid. So these are the things that you need to keep an eye out: weight gain, edema, and a increase in the blood pressure, and also the blood sugar. Okay, hyperglycemia. There's so many things that can happen with glucocorticoid therapy, right? So aside from the retention of water, there will be weight gain, there will be edema, there's going to be increased blood pressure, increased blood sugar, and moving forwards, they're going to be prone to developing those opportunistic infections as well. What about letter E? Dark, sticky stools. Yeah, that's quite a descriptive about the stools there. Sticky stools. Well, the prednisone is an oral medication. We are talking about the oral drug. This is a tablet, oral corticosteroid. And remember that this is a medication that is highly irritating to the gastric mucosa. To the gastric mucosa. Okay, it's basically going to cause an ulcer, to be honest, and to be short, it can cause ulcers. And when this happens, if there is going to be erosion into the lining of the stomach, it can lead into GI bleeding. Yeah. It doesn't take long for this medication to cause GI bleeding. So you got to be careful when you are administering this medication. It has to be given with meals. All right? Don't just give it with just a regular 240 mLs of water and that's it. No, please give it with meals, to be exact. Maybe a snack would do, but giving it with a meal would really help out. Okay, make sure that we are preventing the erosion, the gastritis, and also the end result, GI bleeding. Okay, we don't want this. And so if there is a GI bleeding that can occur to our patient, what can happen is that they're going to end up with dark, tarry stools. That's what basically is dark, sticky stools. Dark, tarry stools. So if there is now a change in the color of their stools from being chocolate brown into black, yeah, that's a huge difference right there. That simply means that there is now an old blood that could have passed in from the upper GI tract, from maybe the gastric mucosa in the duodenum, and then it's eventually passed into the lower GI tract, the intestines. Okay, and so it's going to come out as dark, tarry stools. So this will need to be tested. Let's say, for example, the Hemocolt test. Okay, Hemocolt testing or the guaiac testing. So this is going to be a follow-up test to determine if the patient has developed the GI bleed secondary to taking the corticosteroid prednisone. Okay, so you got to pay attention, guys, with the poop of our patient. Sometimes they will like, why are you watching my poop? Yeah, I need to watch your poop because you're taking a medication that can ulcerate your stomach and also the small intestine, the duodenum. So you have to really assess your patient, especially with this kind of medication. Again, it is an ulcerant. All right. So our adverse effects, again, we have what? Low potassium levels, hypokalemia. We have retaining fluid or fluid retention, and the dark sticky stools. Okay, why did we not select rapid heartbeat? Why not letter B? So let me erase this because this is getting busy as an airport. Rapid heartbeat, why not tachycardia? Well, because the medication doesn't, it's not associated with the rhythm, or let's say the heartbeat. No, it doesn't cause that kind of alteration. Okay, so the rapid heartbeat or the tachycardia, this is often associated with cardiac stimulants or for those medications that are intended for blood pressure control. Okay, so it's not really going to do a lot of the rapid change. Why not letter D, feeling nauseous? Well, nausea is not really an adverse effect. Okay, it could be a side effect. We're talking about an adverse effect here. The patient might feel nauseous because of the irritation in the stomach, but it's not about adverse effect. Okay, so that's why we are going to eliminate that one. Okay, all right. So our test taking strategy that you need to remember in answering this kind of question, you got to make sure that you are able to recall the medication side effects. You got to be familiarized with those side effects, adverse effects, and also to prioritize the monitoring. Okay, you have to focus on the responses that will reflect the need for ongoing monitoring or potential adverse effects. Okay, all right. Now let's move on to the next question, which is going to be question number 7. The nurse assigned to a patient with a chest tube drainage is assessing the function of the drainage setup. Let me read that again. The nurse assigned to a patient with a chest tube drainage is assessing the function of the drainage setup. Which of the following observations are typical? Select all that apply. All right, we're back to the chest tube again, guys. Which of the following observations are typical? Select all that apply. A, the drainage system placed in upright position at chest level. B, sutures exposed without addressing. Or C, water level in the water seal chamber is rising and falling with breathing. And D, steady gentle bubbling in the suction control chamber. And E, we have continuous bubbling in the water seal compartment. Again, the question is, which of the following observations are typical? Select all that apply. And we are being asked on a patient with a chest tube drainage. Okay, so if we are being asked about typical, what is normal? Okay, so your answers are A, C, C, D, E, C, D. All right, C, D, E, C, D. Who else? I need to see some more answers from you guys. Boss Babe, C, D. Water level in the water seal chamber rising and falling with breathing, and steady gentle bubbling in the suction control chamber. Okay. All right. Let's reveal the answers, guys. Okay. We will find out in a minute. All right. So the correct answers for this SATA question is or are letter C, which is water level in the water sealed chamber, rising and falling with breathing. The other one is also D. We have steady, gentle bubbling in the suction control chamber. Okay, guys, I want you to think, have a mental picture about the water, or the entire the what do you call this? The device itself, the water seal compartment, the drainage chamber, and the suction chamber. I want you to really stick this in your memory. Give that mental picture of the Pleurovac system so you won't forget, okay? Because this is going to be tricky if you're not really familiar with the drainage, the sequencing. I win, give me $1 million. Okay, yeah, maybe you can share that with me as well. That would be great. So the answers are C and D. Let me explain why C and D. Well, because it is expected, especially in the water seal chamber, when the patient breathes in, it actually goes up. And when the patient exhales, the water level goes down. All right? So, this is a normal finding, guys, when we are looking into the water seal chamber. So for the meantime, I'll just draw here, even though I have it in the next page. We'll just make use of my temporary setup here. So supposing this is the Pleurovac system, this is going to catch the drainage from the patient's chest. So this is going to be our drainage compartment. And then this is going to be the water seal, right? And then this is going to be the chamber that will be connected to the suction. Suction, water seal, drainage, SWD. All right? So don't forget that. SWD, suction, water seal, and we got the drainage compartment. So here, take a look into the letter C option. Water level in the water seal chamber, rising and falling with breathing. Okay. So what it simply means is that this will fluctuate. It's not going to be rapid fluctuation, but it's going to be even. It is going to mirror with the patient's breathing. So the water level will elevate when the patient breathes in, and it will go down when the patient exhales. So that is pretty much goes with the patient's inhalation and expiration. So this is an expected finding, guys. Okay, letter C. Water level in the water sealed chamber rising and falling with breathing. This is normal. Okay, so that's why it's correct. Now moving into the next option, the other correct answer, steady, gentle bubbling in the suction control chamber. And this is going to be this section right here. Okay. So what it's simply saying is that there is a gentle bubbling. It's not vigorous, okay? So just small appearance of those tiny bubbles, gentle appearance of those bubbles. It's in the suction chamber, guys. So this is a normal finding as well, okay? So it's pretty much gonna tell us that the suction chamber is functioning normally, okay? It's functioning properly. If you're gonna see those tiny bubbles coming up, okay, this is going to be steady, gentle. All right, now why is a wrong option? Okay, let me erase this right here so it will not be confusing for you guys. Why is letter A wrong? The reason for that, it's because the statement said something about the drainage system placed in upright position. Yeah, it has to be in upright position. Make sure that it's not tilted to one side. Make sure that it's planted on the ground well. Make sure that it's not going to be tipped over, okay? So make sure that this is anchored well. No chances at all that it will fall backwards or forwards. We don't want that. Make sure that it is below the patient's chest, not at the chest level. That's why it is wrong. Okay. We're not going to expect proper drainage coming from the chest if the drainage system is at the same level. No, of course not. Okay. It should below the chest level. And it is a good practice to make sure that this is planted firmly on the floor. Make sure that those, usually the pleural evac, let me just draw here, like it has that kind of like stand. So it will stabilize the position of your pleural evac. Make sure that this is going to be secured. It's not going to fall over to the back or the side. Yeah, make sure that it is secured. Okay. What about letter B? Sutures exposed without addressing. Well, that is quite obvious, right? You got to eliminate that one. Anything that is already get involved about puncturing, maybe there's a insertion of a chest tube, there should be a sterile dressing that will cover that one. It should not be exposed, okay? Because this can promote microorganism growth into that area, and also the atmospheric air can readily enter into the pleural space without that occlusive dressing. Okay, make sure that you have that dressing readily intact, dry and intact. Clean, dry, and intact, CDI. Now let's talk about letter E, continuous bubbling in the water seal compartment. We are talking about this one, water seal. If there is continuous bubbling, hey, that's not good. Bubbling, it's going to signify that there is a leak, right? Continuous bubbling is going to signify that there is leaking. All right. So guys, before we move forward to the next question, the focus of this test question is actually going to evaluate your skill in assessing the setup. So what is that observation skill? Well, what you're going to need to do is to look for the titling. Okay. Yes. Virtuous lady is correct. If there is continuous bubbling in the water seal chamber, that simply means that there is leaking. And it could be a leak coming from the chest tube itself, or it could be there is a disconnection, or maybe the connection of the tubing with the pleural evac system is not so, it's not tightly joined together. So it's allowing the atmospheric air to go in the system as well. So air leak is never good. So again, this test item is going to test you how well you're able to watch for the titling. So what is the titling? This is actually the movement of the water inside the water seal chamber. So like I've said, when there is inhalation, the level of the water will go up, and it will also go down when the patient exhales. So that is what we call as titling. Okay. Titling, yeah, there could be a tension pneumothorax as well if there is now bubbling, continuous bubbling. We don't want that as well, okay? So back to the titling. This is very simple, guys. You don't have to really complicate things just with the chest tube. It's easy. Just simplify things. Do not make yourself so confused. Just remember about the titling. What will be the chamber that you should look for? Titling will be on the water seal. Okay, so again, it's normal to see the elevation, just that gentle elevation and depression of the water level when the patient breathes in and out. That's the titling. And it is going to be in synchrony with the patient's spontaneous breathing. Okay, once the patient inhales, it goes up. Once the patient exhales, it will go down. Now, if there is a lack of titling, there is no longer an upward movement of the water level or a downward movement of the water level, then this can be a concern for you guys. Okay, it simply means that there is no more titling. Let me erase this. If there is less titling, then this will signify that there is a tubing obstruction. So let's talk about the titling first before we go into the leaking, okay? Tubing obstruction. So what could cause the obstruction? Well, maybe that there is a kink in the tubing itself, or it could be that there could be some compression in the tubing, or it could be a collapsed lung as well, okay? Now, if there is going to be that bubbling, okay, hang on a second. If there is a decreased titling, we're talking about the decrease in the titling, then the person probably will have some chest tube displacement as well. Maybe a accidental pull from the chest tube itself. Then this is gonna need some adequate investigation, looking for the site, make sure that we have to do a follow-up chest x-ray if there is less titling, because it can signify that there is now chest tube displacement. All right, or if there is probably some system leak. Okay, if there is a leak, then the titling will be lesser. All right, now there's probably resolved hemothorax. Let's say, for example, if it's been day 4 or 5 days after the insertion of the chest tube, and so if there is less titling, it could be a good outcome. It could signal that the patient's hemothorax has been resolved. So again, we have to follow up that with the chest x-ray to make sure that we are looking into the integrity of the pleural space and to see if there is residual volume in there. Maybe there's still pneumothorax, if there's still hydrothorax. So this is going to be done in a daily basis. I'm talking about the chest x-ray. Now, if we are gonna look for the bubbling, and if it is going to be specified in the test question, bubbling in the water seal, it's never good, guys. Bubbling in the water seal chamber is never good. A continuous bubbling simply means that there is an air leak. Okay? Continuous bubbling. Let me just write here. Continuous bubbling in the water seal signifies air leak. However, if there is intermittent, okay, please take note of the key words here. If this is going to be intermittent bubbling in the water seal, then it will signify that it is expected, okay, especially in the freshly placed chest tube. If there is intermittent bubbling, then this is expected, especially during just after the insertion. This is expected when the chest tube has just been put in by the medical provider. It's expected, intermittent bubbling. But if you are going to see continuous bubbling, that is so different, okay? That simply means that there is air leak. Now, let's talk about absence of bubbling. Oops. Yeah, that's the picture that I was talking about, but we'll go to that section in a minute. If we're talking about the absence of bubbling, good morning. All right. It simply means that what happened? Yeah. Okay. So when the patient has absence bubbling, this is going to signify that there is already healing. Okay. The pneumothorax has already been evacuated. Pneumothorax evacuation. No more bubbling. Pneumothorax evacuation. Let me erase this. Okay. So I really want you to differentiate the terminologies here. If there is continuous bubbling, that signifies air leak. If there is intermittent bubbling in the water seal, that simply means that, hey, the the appliance is still working. It is expected, especially right after the insertion, okay? If there is absence of bubbling, this is normal, especially when the patient has had the chest tube for quite a few days now. That means that the pneumothorax has been evacuated, all right? All right, so I hope that you're able to understand simply about the titling and bubbling. That's pretty much it. You're going to be tested on how are you going to interpret those titling and the bubbling, okay? Now let's proceed to this picture right here. So this is basically what I was mentioning. This is the drainage collection right here. E should rather have been intermittent bubbling. Yeah, let me take a look into that question. Letter E? No. Letter E, continuous bubbling. So what was the answer here? Hang on a sec. The correct answers for this scenario, which of the following observations are typical? Select all that apply. So the answers are C, D. Water level should be the rise and fall with the patient's breathing, steady, gentle bubbling, and E, continuous bubbling in the water seal compartment. Well, if we are going to answer continuous bubbling, this is going to signify that there is an air leak, right? If it's going to say intermittent bubbling in the water seal compartment, this could be acceptable as a typical finding, okay? That simply means that, yeah, this is expected. The chest tube is working, okay? But the continuous bubbling is making it erroneous. All right, so make sure you remember the continuous bubbling, intermittent, and absence of bubbling. Okay, so just I'm gonna give you a better idea, really, the differences between those characteristics. Okay, let's go back to that picture right there. So we have our drainage system collection. Let me change my laser pointer. So basically right here, so this is that chamber which can catch the drainage coming from the patient's chest. So for example, if the patient has hemothorax or hydrothorax, all those fluids will go inside this drainage section. And of course, if the patient has pneumothorax, when the patient breathes in and out, and let's say, for example, if they are taking a deep breath or coughing, this will also facilitate the removal of the pneumothorax from the pleural space, and it will go into the drainage collection. Of course, it's not going to go down by gravity, right? It's air, so it will accumulate here as well. But talking about the water seal, this is right here, okay? So the fluctuation I'm talking about with the titling is right here. Same thing with the bubbling. If we are going to be asked about the intermittent, continuous, absence of bubbling, it's right in the water seal. But if in some cases wherein you're going to be asking the NCLEX and it's specifying bubbling in the suction chamber, this is right here. So if there is gentle bubbling in the suction compartment, that is normal, guys. You don't worry about that, okay, if it's in the suction. However, if you're going to see continuous bubbling in the water seal, it's never good. It is a sign that there is air leak, all right? And that's pretty much it. I'm not going to add anymore, so I don't want to overload your brains. I just want to simplify. All right, let's move on to the next question. Question number 8. A nurse is preparing care for a client after a chest tube and drainage system have been inserted. Which actions should be part of the care plan? Select all that apply. Again, the question states, a nurse is preparing care for a client after a chest tube and drainage system have been inserted. Which actions should be part of the care plan? Select all that apply. Is it A, promote coughing and deep breathing in the client, monitor for ongoing bubbling in the suction chamber, or C, milk the drainage tubing every 4 hours, D, apply a clamp to the tube daily, and E, arrange for a chest x-ray. So the scenario stated, a nurse is preparing care for a client after a chest tube and drainage system have been inserted. Which action should be part of the care plan? Select all that apply. So your task here is to select those good nursing actions. Okay, it's not asking for priorities here, just asking you what are the good interventions that you can do for this patient with a chest tube. It's not time sensitive. Mary answered ABE, promote coughing and deep breathing in the client. And B, monitor for ongoing bubbling in the suction container. And E, arrange for a chest x-ray. Jared answered BDE, monitor for ongoing bubbling in the suction container, and apply a clamp to the tube daily, and arranging for a chest x-ray. Guys, you got to be careful with your selections here. All right? You got to be careful. All right, we have Roberta answering ABE. We have Virtuous Lady answering ABE as well. Okay, let's find out. All right, Patience Tumasak answered ED and Joyce answered ABE. All right, very good. Some of you have some correct answers, and some of you had answered the 3 correct answers. Very good, perfect. So the correct answers here, guys, are letters A, we have letter B, and letter E. Okay. Let me explain why you need to promote coughing and deep breathing in the client with a chest tube. Okay. Why? The reason that you need to do this is to make sure that you are promoting the expansion of the lungs when they do the deep breathing. When they do the coughing, this will allow the exhalation. It will allow the removal of the pneumothorax to go into the drainage system. Okay, that's the reason why coughing can be beneficial for this patient. Not vigorous coughing, but those regular exercises that we're gonna have to implement for our patient. They need to do the coughing and deep breathing exercises. All right. So again, the reason for the deep breathing is to allow maximum expansion of the lung fields, and also to allow, with the coughing, it will allow the exhalation of those pneumothorax to go into the water seal. Now, what about letter B? Monitor for ongoing bubbling in the suction container. Again, this is a good indicator that the system is working well. Suction container, right? That was the suction that I was showing you earlier. If there is ongoing bubbling, this is simply an indication that the system is working well. You don't worry about that at all. Okay? All right. Now, for letter E, arrange for a chest x-ray. This is going to be done in a daily basis once the patient will have the chest tube in place. Okay? This is going to be done as a standard procedure, daily chest x-ray, especially early in the morning. And the reason for that is to evaluate if the tube is still well in place, and also to make sure that we are monitoring for lung re-expansion. That is the reason why a chest x-ray is going to be conducted in a daily manner to check for the lung re-expansion. Because when you have a lungs that has the, yeah, my lungs right here looks like an avocado, right? So, for example, if the patient has pneumothorax, so it can compress the lungs. Of course, it will stay on the apex part of the lungs, right? Because it's a gas. So if there is an accumulation, a significant amount of pneumothorax, it can compress the lung tissue. So the lungs will not be able to expand well when the patient breathes in. And so it can impede the inhalation and exhalation. The patient will not be getting enough air into the alveoli. And so when we have that patient with a chest tube in place, we want to make sure that there is daily chest x-ray to check if there is now removal of the extra air, the pneumothorax, okay? Because in the a potato, yeah, my lungs look like a potato. So guys, remember about the placement of the chest tube. If it is a pneumothorax, the entry site of the catheter will be close to the apex, because we are expecting that the gas will be staying in the upper portion of the lungs, right? And so of course, the insertion site will be on the upper part of the lung, not on the lower part, okay? So this will allow the exit of the pneumothorax into the tube. It will go into the water seal chamber. However, if you have a patient that has a hydrothorax or hemothorax rather, so for example, chest trauma, so let's say a collection of blood over here, again, it's gonna compress the lung as well. If there is way too much accumulation of blood or pus or fluids, it can also compress the lung, so it cannot inflate properly when you are breathing in or out. And so the insertion site for the catheter will be in the lower section of the lung field as well, in order to get rid of that accumulated fluid. Okay, so back to the chest x-ray. We are expecting that the x-ray will be done in a daily manner in order to evaluate for the lung re-expansion. That is one. And the other reason is to make sure that the placement of the chest tube is confirmed. Okay, make sure that there is proper placement of the tube. So to check if there is dislodgement. Okay, so that is the reason why a chest x-ray is to be done. All right. So those are the correct answers, guys. A, B, and E. Why not letter C? Can you give me a reason why letter C is wrong? Can you tell me? Why is letter C wrong? Milk the drainage tubing every 4 hours. Why is this wrong? I want your answers here, because in the previous years, way back in my time as a nursing student, way back in the 1990s, stripping and milking was actually promoted. Yeah, it was in the reviewers, nursing review books, and also in the nursing textbooks, that stripping and milking is supposed to be done in a patient with a chest tube. Not anymore. And so the reason that the stripping and also the milking is no longer applicable, it is because it can damage the lung tissue. It can disrupt the negative pressure in the pleural space. It can lead to tension pneumothorax. We don't want that. Again, tension pneumothorax simply means that it can damage the lung tissue. It can also disrupt the negative pressure, and it can also create more presence of air, pneumothorax. Air presence, right? It's abnormal. So we don't want the milking. We don't want to strip the tubing unnecessarily. That's why it's no longer a standard procedure for this. What means milk the drainage exactly? So milking basically is your stripping. You're compressing the tube. And the reason for that in the previous practice is to get rid of those fibrin materials that could be obstructing the tubing, especially if the patient has hemo or what do you call this, hemothorax or hydrothorax, really thick secretions. And so it was supposed to be done like regularly every 4 hours here in the past. It's no longer a practice now because it can cause tension pneumothorax. Yeah, we don't do that anymore according to the evidence-based practice. Okay, and same thing with the application of a clamp to the tube daily. We're not supposed to do that also. There should be no clamping up unless if there's a need for us to change the appliance, or to momentarily check for any air leak, then that is an exception. We can apply clamps or just momentarily application of the clamp if in case we're only going to have to troubleshoot where the source of the leak is. We can do the clamping, but only for a short period. We don't have to clamp it daily. There's no use of that. It can only harm the patient. All right. So the same result will happen. Tension pneumothorax. It can lead to that air trapping or fluid in the pleural space. We don't want those guys. So again, let me emphasize. Only A, only E, and monitor for the bubbling in the suction chamber. Not water seal, but suction. All right, so I hope that you're able to get a better understanding really about the care in the chest tube, okay? So you really need to consider those nursing interventions that that would really promote safety of our patient, not to harm our patient. So disregard those old nursing practices that are no longer effective, okay? All right, let's talk about the nursing. Next question, number 9. A nurse is creating a home care plan for a patient who was treated for tuberculosis. Which instructions should be included? Select all that apply. Oh boy, I repeated the select all that apply words here. All right, just one. Again, the question stated, a nurse is creating a home care plan for a patient who was treated for tuberculosis. Which instructions should be included? Select all that apply. Is it A, resume activities gradually? B, avoid contact with people outside the family for at least 6 months? Or C, obtain a sputum culture every 2 to 4 weeks after starting medication? Or D, respiratory isolation at home is not needed since the family has already been exposed? E, cover your mouth and nose when coughing or sneezing and dispose of tissues in the plastic bags? And lastly, letter F, after one negative sputum culture, you are no longer infectious and can usually return to work. All right. Read through the selections here, guys. Be careful with answering the SATA question. Obey answered A, B, C, and E. Okay. What about the rest? What are your selections? Okay, what happened to the rest? Are you still choosing the answers, guys? Okay, let me just wait for your answers. Mary answered A, C, D, E. Okay. What about the others? While waiting for the rest of the class to answer, let me just fix that. Select all that apply. Page 387. All right. I'm seeing more answers. Very good. Okay. Jared answered ACE, Diagnoblin BCE, Mary ACDE, Joyce ABE, Virtuous Lady ACDF, Okioma ABCE, Nargisa ABCE, Miss Flynn AEC, Virtuous Lady ACDE. Okay. And Roberta answered ACDE. Let's reveal the answers. It's very important, guys, because the tuberculosis treatment has quite changed, and we also need to make sure that we are providing the patient with the accurate information and how they're gonna be up and about, especially in the public once they get the treatment. And so let's reveal the answers, guys. The questions. The question is stating a nurse is creating a home care plan for a patient who was treated for TB. Which instructions should be included? Select all that apply. All right. So if you had answered letter A, resume activities daily. That is one of the correct answers. And I will do the rationals in a minute. If you had answered letter C, obtain a sputum culture every 2 to 4 weeks after starting the medication. And this is pertaining to the anti-tubercular medications. That's also correct. If you answered letter E, cover your mouth and nose when coughing and sneezing and dispose of tissues in plastic bags. That's also correct. If you had answered letter F, after one, hang on a sec here. No, that is not a correct answer. Eliminate that. So our correct answer is letters A, C, D, and E. I skipped the letter D. So again, resume the activities gradually, obtain sputum culture every 2 to 4 weeks after starting medication, and D, respiratory isolation at home isn't needed since the family has already been exposed. That is true, guys. And letter E, cover your mouth and nose when coughing or sneezing and dispose of the tissues that were used. Okay, let's talk about letter A first. We are going to tell the patient that they need to gradually resume the activities, and we don't want them to really engage in much more strenuous physical activity because they definitely need to get used to, we don't want to overwhelm our patient with so many physical activities. They need to conserve their energy and stamina in order to allow tissue healing. So that's the reason why we need to pace their physical activity until they will get used to that level. Okay, so gradual increment of physical activity. That is what it meant here. Okay, so what about letter C? Obtain a sputum specimen every sputum culture rather. Of course, the reason for that is to make sure to evaluate if there is still that presence of the Mycobacterium tuberculosis in the sputum. And this is going to be done at least every 2 to 4 weeks after starting the anti-tubercular medication. Okay, so this is the standard treatment procedure. Okay, and again, this is to determine if the patient is no longer infectious. That's the reason that we need to do the sputum culturing every 2 to 4 weeks. Now, if you had answered respiratory isolation, hello, do you do personal lecture 1-on-1? No, I haven't done really a personal lecture virtually. No, I haven't. I would like to try, but no, not at this moment. Thank you, though. So we have letter D. Respiratory isolation at home isn't needed. Yes, that is quite true. Because when the patient has been diagnosed, or before they were diagnosed, if they were living together with the same family members, same people that live in that household, of course, they have already been exposed. It doesn't mean that they need to neglect observing the isolation as well, or neglect or be what do you call this, reckless in exposing themselves into the public. No, I'm not talking about that, but it simply means that when we are telling them that they're not going to require isolation at home, that they don't have to put themselves in their bedroom for the whole time up until all their testings are negative. No, there is not really a need for them to be isolated in a particular room in their home. Because again, the reason for that is because all the people that have stayed with that patient since before the diagnosis could have been exposed already. But Of course, if there are going to be visitors, of course, they don't have to be exposed to that patient, right? No. I'm only talking about the family members that who lived with a patient before and during or after the diagnosis has been established. Okay, so they don't need to place the patient in an isolation. So that is what this section means. Now, E, cover your mouth and nose when coughing or sneezing. Yeah, this is very a generic kind of teaching, especially with disposing off the contaminated tissues. That is also correct. Now, we are going to talk about the other options. What are those options? Resume activities, obtain culture, D, respiratory isolation, and E. So we have the remainder here, B, which is avoid contact with people outside the family for at least 6 months. That sounds so kind of like over the top, okay? It seems kind of like a good intervention or good teaching to avoid contact with people outside the family for at least 6 months. That is way over the top. That is an overkill, because we are going to test the patient's sputum. Remember that the sputum examination for the acid-fast bacilli will be done every 2 to 4 weeks. Remember, if the patient is no longer positive at least how many times? That was like 3 times, right? Remember the frequency of the sputum culture, the amount of the testing. So if the patient has been negative for the several times, then they don't need to be, they don't have to do this avoidance contact for the entire 6 months. That's way too much. So as long as the patient has been negative with the microorganism with that minimum amount, then they can be outside, okay? Be in the public. They still need to wear their mask though, but again, they don't have to be confined in their home setting or isolated, okay? Now, if letter F was your answer here, after 1 negative sputum culture, you are no longer infectious and can usually return to work. This is false. Talking about 1 negative sputum culture is wrong. The criterion here is going to be more than once, okay? This should be about 3 times negative, okay? I wasn't sure of answer C. Okay. I hope that you were able to get the explanation this time though. Okay. I hope that. All right. So with letter F, after 1 negative sputum culture, you are no longer infectious and can usually return to work. This makes the statement wrong. 1 negative culture. This is wrong. All right. So again, the criterion here is 3 negative sputum tests. So the person should not be isolated for the 6-month period because it's dependent on the sputum culture result. At least 3 of those sputum culture and in a series of 3 testing. All right. So that's what is this question all about. Now, we're going to move forward with the next question here, guys. Question number 10. Very good. Chica Julius. All right. Where are you from, Chica? So question number 10. While caring for a client on mechanical ventilation. I will read some 2 to 3 days torturing before my exam. Torturing. Did you say torturing? You don't want the torturing, right? Maybe tutoring. Okay. Question number 10. While caring for a client on mechanical ventilation with an endotracheal tube, which action should the nurse prioritize? Is it A, use a vest restraint in case of attempted self-extubation? B, check ventilator settings every 8 hours? Or C, record the tube placement measurement in centimeters at the jawline? And D, evaluate breath sounds every 4 hours. Guys, this is a little bit like uncommon, right? Yeah, maybe you are kind of like, hey, I really don't want to engage myself with the ventilator settings. I hate that. I don't understand about that. But you really need to understand here, even the basic settings with a ventilator, because you cannot avoid it, especially if this is going to be one of the test items. And so you really need to overcome the fear. Yeah, just like me. There are some things that I really don't like to listen, especially maternal and child nursing. I really don't like that subject. I hate maternal nursing, but I was forced to study it when I took my license exam. Yeah, I really hated MCN, and yeah, that's true. And so here, if you're not liking about ventilator settings, tracheostomy, those kind of things, you really have to force yourself. You have to desensitize yourself from those um, difficult concepts. Okay, so what is your answer? We have seen D, C, C, C. Okay, so what is your answer? Which action should the nurse prioritize? So the patient or the nurse is caring for a client with a patient on mechanical ventilation with endotracheal tube. All right. Okay. So what is your safest answer here? The answer is letter D. That's the minimum. Evaluate the breath sounds every 4 hours. Minimum. It doesn't say that this should be every 4 hours. Okay. It's just like implying that you have to do it with this kind of like minimal amount or minimum frequency of every 4 hours. You can do the auscultation, the breath sounds, as often as you want. If you are doubting about the symmetry of the chest, if you really wanted to investigate further, you can do your assessment more than that. Okay. And why is this letter D correct? Why do we need to check the breath sounds every 4 hours at least? Well, remember that when a patient is intubated with an artificial tube, that endotracheal tube, potentially the tube can get dislodged, right? Because the patient will not be sitting or be in a 45 degrees angle the whole time. You're going to have to reposition the patient. You're going to have to provide oral care to the patient. If the patient will end up with pooping, if they are incontinent, if there's no urinary catheter, probably you're going to have to clean them for the urinary incontinence. Or if they are pooping, then you have to do the number 2 cleanup, right? And so all these things, the repositioning, the other care that you're providing to the patient can potentially cause some dislodgement of the endotracheal tube. And aside from that's not just the reason why we are really going to auscultate. We really want to make sure that the placement of the ET tube is in the right spot. Because if there is now an even sound when you're auscultating the lung fields, then that could mean that the tube has migrated. It is now malpositioned. It's now probably aerating just one side of the lung. And it could probably lead into the pneumothorax, right? Pneumothorax is a common complication in mechanical ventilation and endotracheal intubation. Pneumothorax is one of those. Another is mucus plug. Mucus plug. It's because the airway is open. It can dry up the yeah, that's correct, virtuous lady. Mucus plug can easily form. This is very thick. It will be difficult for us to suction if we are not going to take care of this. And again, this can impair the exchange of gas. Maybe now you're only hearing the breath sounds into the right or maybe just the left side. So you gotta have to pay attention to the lung sounds here. And we want to make sure that our patient is checked if there is dislodgement for the tube. Those are the main reason. Check for those asymmetrical movement of the chest. We want to make sure that we have to follow up that with auscultation. That's one reason for that. Why not letter A? Use a vest restraint in case of attempted self-extubation. Have you seen this in the clinicals, guys? Vest restraint. Have you seen this? I myself have applied vest restraint in one of maybe several of my patients that were very combative in the past. But in the other hospitals that I've worked with, we don't use the vest anymore. We've only used the minimal type of restraints like the wrist restraints or the roll belt. But really, I don't like the use of restraints on my patients, just to be honest with you. I hated it. The more that you're going to tie down your patient, the more that you really have to monitor your patient. No, this is multiple choice only. So the correct answer for that was letter D. Okay, so we are just rationalizing the other options here. So letter A is wrong. The reason for that, it's because we don't really want to like cause more agitation in the patient. Okay, wrist restraint, yeah. Only if the patient really is kind of like do a lot of those weird stuff, pulling, tubings, nasogastric tube, IVs. Yeah. And so when we are using the vest restraint of the patient, this is a kind of like an overkill. All right. We want to make sure that we are applying at least the least amount of restraint to the patient. And we can start with the wrist restraints. Okay. And we need to follow by the rules, the policies and the procedures of the institution. Okay. You have to really follow through about when to apply and the frequency of the assessments, because there's a whole lot of other nursing stuff that will be involved when you are applying the wrist restraint to the patient. Again, the vest restraint is not necessary in that scenario. If we had answered letter B, check the ventilator settings every 8 hours. Every 8 hours, that is kind of like way too distant from the regular frequency. We have to check the settings on the ventilator at least every hour or as often as we can in order to make sure that complications are avoided, right? So every 8 hours is way too long for us to check the settings. Letter C, record the tube placement measurement in centimeters at the jawline. This practice is not really advised in taking care of a patient with an endotracheal tube and also mechanical ventilation. We can document the tube placement though, that is important, but measuring it in centimeters at the jawline is not a standard method. It will not really help us in determining the proper placement of the tube into the airway. Okay, so it's not really going to give us a better idea if the tube has been advanced or it could have been pulled out slightly. No, we really want to make sure that if there is a suspicion that the tube has been dislodged, then we are going to confirm that with the use of a chest x-ray. Okay, or possibly the confirmation at the lips or rather teeth rather than at the jawline. Okay, so just to be safe, we are going to go for the chest x-ray confirmation to evaluate placement of the endotracheal tube in the airway. All right, so using the measurement through the jawline area, it's not going to be a reliable intervention. Okay, so our goal here in this question is to check if you're able to maintain the patient's safety and also to prevent the complications associated with mechanical ventilation, and also to detect those early signs of complication. Okay, so caused by maybe the mucus plug, or it could be the pneumothorax. So we really want you to exercise your critical judgment here. All right, now we're going to have to move forwards with the next question. What time is it? Okay. A patient experiencing acute shortness of breath is admitted to the hospital. What should the nurse do first during the initial assessment? Again, let me read back the question. But patient is sedated or unconscious. chemical restraint. Ubay, can you please elaborate with your statement there? I want to answer your question here, but I need to get a clarification of what the question is all about. Okay, let me get back to you. So the question stated, a patient experiencing acute shortness of breath is admitted to the hospital. What should the nurse do first? Sedating a patient in this condition instead of the other methods considered restraint. Chemical restraint, yes. Yes. And most often, our patient will be given not the sedative, but one of those paralyzing agents to actually allow the ventilator work better in order to allow compliance. Because if there is some kind of a resistance going on, then our patient will not get the benefit of the ventilator. Okay, we want to make sure that their lungs is compliant to the mechanical ventilation, and so we're going to give them the paralyzing agents that like the vicuronium. Okay, and that is to help allow compliance during the mechanical ventilation. All right. It really depends on the facility, guys, with the use of the chemical restraints or the what do you call this, the physical restraint. It has to be dependent, maybe because the patient is not getting getting enough O2. Okay, so you got to make sure that you have to assess your patient and find out, investigate some more what caused the restlessness. Okay, so let's go into this question here. A patient experiencing acute shortness of breath is admitted to the hospital. What should the nurse do first during the initial assessment? Okay, have the patient lie down to perform a complete physical assessment or exam, or is it B, quickly ask focused questions about the current respiratory issue, or is it C, finish the admission paperwork and check for allergies before starting the treatment, and lastly, letter D, postpone the physical exam until pulmonary function tests are completed. Guys, your patient is having shortness of breath. And you are the nurse assigned to this patient and doing the initial assessment. Looks like you are answering letter B, 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 and some others answered letter D. Okay. All right, let's take a look into the answer here, guys. So you are the nurse taking care of this patient with acute shortness of breath. And supposing you are the first one dealing with this patient, you have to get some information, right? It will be crucial for us to obtain some information in order that we can treat this patient carefully. Okay, so at some point we will be asking some questions, but don't overdo it, or don't do the complete examination at this point. If they are short of breath, we are gonna address the issue, which is the shortness of breathing. Okay, so the correct answer here for this question is to what? To quickly ask focused questions about the current respiratory issue. That's pretty much it. Okay, why? The reason for that is when the patient is in a severe respiratory distress, we should at least gather the pertinent information, those very important information only, in order for us to gather the necessary critical information. What we can do here is to defer the full assessment at that point. So that is why B is the correct answer. If you had answered letter A, have the client lie down to perform a complete physical examination, no. Lie down with a patient with a shortness of breathing? Yeah, wrong right away. Okay, you don't have to do the complete physical examination because you have to address first the shortness of breathing, right? The breathing, the ABCs. So you can defer the full examination at a later time once you have addressed the breathing issue. All right, So make sure you address that first. If you had answered letter C, finish the admission paperwork and check for allergies before starting treatment, sounds kind of like a good answer, right? But if you wanted to complete the paperwork first, you're actually neglecting to address the shortness of breath. Okay, so the best answer is letter B as well. Now, if you had answered letter D, postpone the physical exam until pulmonary function tests are completed. Well, this is the exact opposite in the spectrum, right? If you had answered letter D, if you are neglecting to do the physical exam, at least initial exam, okay, then you are lacking some information that would be critical in treating this patient. You need to at least examine the patient. You need to assess, listen to the lung sounds right after or maybe before you ask the patient those pertinent questions. But again, the focus of this question is to evaluate that you are prioritizing your interventions, your action, that you are not delaying the treatment, guys. Take note, we are dealing with a breathing issue next to the airway. Okay? You need to implement those interventions right away as soon as you have gathered those critical information. So here, you're going to ask the patient, hey, how long have you been having the shortness of breath? How does it feel? Like, do you feel like you're going to pass out anytime soon? Or did you take your medications at home, your inhalers? Were you able to take those maintenance medications at home? So those just very pertinent questions at this time, all right? You're going to have to delve with those other questions at a later time once you have obtained those pertinent information, okay? So the focus of this question really is to prioritize the patient needs, especially, and again, we need to address immediately the shortness of breathing in this patient. So you can delay those other nursing interventions that are not really needed in the acute phase. So yeah, you have to prioritize according to the airway, breathing, and the circulation. Shortness of breathing is already critical, guys. Don't neglect that. It is a critical condition, and you need to stabilize the patient first. All right? Alrighty, let's go to the next question. Question number 12. A diabetic patient's arterial blood gas results indicate a pH of 7.27. Partial pressure of the carbon dioxide is 33. And partial pressure of the oxygen is 84 mmHg. And bicarbonate level of 19 mil equivalents per liter. Let me have some water here. What symptom should the nurse anticipate? So your patient is diabetic with an arterial blood gas of pH 7.27, PCO2 of 33, PaO2 of 84, and bicarbonate of 19. What symptom should the nurse anticipate? Is it A? Is it intercostal retractions? With B, in deep rapid breathing? Or is it C, reduced oxygen saturation? D, lower venous oxygen pressure. What is your answer here, guys? With all those lab values in the ABG, what symptom should you anticipate? We're talking about a diabetic patient. I kind of like incorporated this into this question, even though it's not really a respiratory issue, but it's good to have, especially that we're talking about like ABGs, respiratory compensation and stuff. So I've seen letter B's, Margaret, Manish, Virtuous Lady, Elenita, and we have C from Shivani and Miss Flynn, B, and Mary, C. And they answered letter C as well. So our patient with diabetes, what do you think about this patient? What is the problem here, guys? Can you type in what your thoughts are? What do you think is the patient having around this time? What could possibly be going on with this patient? So let's take a look. The pH is 7.27. This is acidic, right? And then we have a PaCO2. I'm not asking really here for you to interpret. No, there's no need for you to interpret. Just take a glance. The carbon dioxide is 33, which is low. Normally, it should be 35 to 45, right? So this is leaning towards the basic side or alkalosis. Now, the PaO2 of 84, which is basically within the range, right? 84 mmHg. Yeah, good job, Miss Flynn. Metabolic acidosis because of the DKA, diabetic ketoacidosis. So basically what you're going to expect here is the Cosmos respiration. And this is a compensation by the lungs to get rid of the what? Acids through the hyperventilation. They're going to end up with rapid and deep respiratory rate in order to attempt in getting rid of the carbonic acid. All right, that's the Cosmos respiration. Yeah. So the deep and rapid breathing is the characteristic or the description for the Cosmos. If you had answered intercostal retractions, this is not isolated to the DKA. It can happen from other respiratory disorders, let's say pneumonia, acute respiratory distress syndrome. If you had answered letter C, yeah, we'll talk about the ABG as well in the next slide. Letter C, reduced oxygen saturation. The patient actually is hyperventilating. And take note here, guys, about the carbon dioxide partial pressure. 33. It's alkalotic. So meaning the body is actually depleted with the carbon dioxide content. So because of the hyperventilation, there's way too much acid exiting the body. That is why there is going to be decreased PaCO2. Now, the PaO2 here is within the range, 84. Normally, it should be like 80 to 100, right? And the pH is going to reflect that the blood the pH itself, the blood is basically acidic at this point, which is characteristic of DKA rather. If you had answered letter D, lower venous oxygen pressure. So what is that? This is not really going to be a symptom in this patient, as like I have said, the oxygenation of the patient is not the issue, okay? The issue here is that the patient is exhaling way too much carbonic acid, okay, to compensate the increased levels of the acidity in the blood. That's why they need to get rid of that, okay? So we will go through the ABGs in the next item here. I'm not going to do it right now because I don't have the values yet, but we will apply the Rome later on. Okay, how about we'll just do it now because somebody's needing this one as well. So when you are basically going to talk about ABG analysis, do not confuse yourself. That is one thing. Keep an open mind, all right? Do not confuse yourself. That's one rule for me. So what are you going to do first? If you have the values, deep breathing sounds a bit unlikely when the patient breathes so quickly, right? Deep breathing is, no, the deep breathing will really have to, you have to really exert effort to allow the maximum lung expansion, okay? But when the patient is hyperventilating, the rate is fast, but also the depth is also kind of like imposed at this moment, okay? So it's not just about the respiratory rate that we are talking about with the hyperventilation. The rate and also the depth is involved, okay? So this is what we call as the Cosmos respiration. Okay. Now, talking about the ABG, I got sidetracked. Okay. So we have the values. Let me just rewrite this. So let's take a look into the pH. Let's try to interpret this one. 7.27. We have a PaO2, the partial pressure of 33. Okay. And then we have the no, I'm sorry. Let me rewrite that. This is supposedly PaO2, PaCO2, and then we have the PaO2, which is basically read as 84. Okay, thank you for the question. And we have the bicarbonate level of 19. Okay, so before you're going to engage in the war of ABG, you have to familiarize yourself first with the values. That's one step, okay, in recognizing that you don't know about the ABG. You always have to have that self-awareness that I don't know about the value. So you have to make sure that you know the reference values. And yeah, always acknowledge that. And I always do that as well. If I'm not familiar with the subject matter, then I have to keep an open mind. So first things first, you need to get the normal values. That's the first step in understanding. So for the pH, what's the normal? Let's do the review right now. For the blood pH, the normal range is supposed to be at 7.35 to 7.45, right? So the blood is basically slightly alkaline because it's over 7.35, so 7.45. The PaCO2 now, which is basically the partial pressure, which is going to be measured in mmHg, okay? So the PaCO2, the normal range for that is 35 to 45 mmHg, okay? And then for the PaO2, the partial pressure of the oxygen, this range will be around 80 to 100. And since it's talking about pressure, the unit of measure here will be mmHg as well. Okay. Now for the bicarbonate, what is this bicarbonate? This is a substance that is going to be secreted by the kidneys, that will be produced by the kidneys in order to buffer the body from elevation of the acids. So basically the bicarbonate is alkaline in nature, all right? Bicarbonate, it's a alkalinizing agent if we are talking about like medication. So the normal range for the bicarbonate is 22 to 26 milliequivalents per liter. That is the normal value, okay? So again, pH, 7.35 to 7.45. The PaCO2 ranges around 35 to 45. And the PaO2 will range normally at 80 to 100 mmHg, and the bicarbonate will range from 22 to 26. Now, let's talk about the patient's level here. The patient's value is 7.27. So take a look into the lower limit of the patient's, the lower limit of the normal range, 7.35. That is the lower cutoff. So this patient's pH is acidic, right? Anything below 7.35 is acidic. Okay. So I want you to do that mental picture that you are chewing on a piece of lemon. How would that be? Would that help? Thinking about the arterial blood gas, if you are thinking about the pH, if you're gonna interpret that as acid, think about chewing on a piece of lemon. Okay, anything below 7.35 is acidic. Now the patient's value is 33 for the carbon dioxide. The reference range is 33 to 45. Okay, so let me move this here, 33 to 45 mmHg. So we will focus on the PaCO2. Anything above 45 in a PaCO2 simply means that this is going to be acidotic. There is way too much carbon dioxide, elevated CO2. If the level is less than 33, then it could mean that the patient will probably have some alkalosis going on. All right. Or this simply means that the patient's CO2 level is low. And that is all about the PaCO2. Again, guys, if you're going to imagine about the carbon dioxide, if it's greater than 45, then that represents acidosis. There is way too much carbon dioxide in the bloodstream. However, if we're going to look into the lower end, less than 33, that means your body is depleted. It's lacking the carbon dioxide in the system. And that simply means that you could probably have some alkalosis going on. All right, so that's about the carbon dioxide. Let's talk about the partial pressure of the oxygen, which is very easy, really. It's like similar to the oxygen saturation. So the range here is 80 to 100 mmHg. And our patient's PaO2 pressure is within the range, 84. So we don't worry about that. Now, talking about the bicarbonate here. So what is this bicarbonate? Like I've said earlier, the bicarbonate is that substance, that alkylinating substance in the body that will be produced to buffer if in case there will be increased acidity in the system, okay? So the patient's value is 19. But before we go to that, let me write this out here. Bicarbonate HCO3 negative. So the normal range is 22 to 26, okay? And the unit of measure is milliequivalents per liter. Okay, so we are talking about a substance that is basically an alkaline, okay? It's basic in nature, all right? So if the number of the bicarbonate exceeds the upper limit of 26, it's already basic, right? So if it goes beyond the 26, then simply, easy, the patient has alkalosis, right? And the exact opposite, if the patient's bicarbonate level drops below the 22, then the patient is lacking the alkalinizing agent in the body. So simply means there is going to be an acidosis going on. All right? So that would be my first step in understanding the ABG, okay? You got to know your reference ranges, the normal ranges. Now, next to that will be to interpret, okay? How I'm gonna interpret the acid-base imbalance here. There are different techniques, okay? One of those will be the use of the Rome, okay? And this might take a while for you guys to remember, but with continuous practice, this can actually retain for life. Yeah, I'm not kidding. It will take a while for you to learn, but with repetitive practice, you will be able to retain this. And I have so many students back when I was still a faculty in the early 2000s. Most of my students back then were able to understand the ABGs, and they're already USRNs or NCLEX, or actually nurses in the US right now. And they really had retained the concept, which I was like, oh, that's good. Somebody has learned my lesson. And so another technique to do here is to go by the Rome method. So what is that Rome method? This simply means that with the respiratory, R stands for respiratory, O stands for opposite, and M stands for metabolic, and E stands for equal. Okay? So this is another technique. I really don't use this. I just eye my values. But for some people, they like to use the Rome, but for me, I don't. But for the benefit of this class, I'm gonna explain this to you, okay? What do we do with that Rome, okay? So let's go back to the concept here. Let me erase this first. Why Rome is significant. All right. So that's enough right there. The Rome is very important for you to recall because the pH and the PaCO2 goes actually, let me start this first. The pH and the PaCO2 have the same kind of like leaning. So for example, if the pH is going to be less than 7.35, what does that mean? If the pH is less than 0.37 or 7.35, that simply means that it is acidic, right? Okay. And if the PaCO2 is, let's say, less than 35, what do you think about that one? If the partial pressure of the carbon dioxide is less than 35 rather, what do you think about that? It simply means that the body is depleted of the carbon dioxide, right? So they are the exact opposite, guys. This one is acidic, whereas the carbon dioxide is alkalotic. That is why it said Rome respiratory opposite. Okay, alkalotic. So basically, the lower ends of each of these lab values are not synonymous. They don't go on the same kind of interpretation. Okay, so for the pH, if it goes low, it means acidic. However, if the CO2 is low or less than 35, it's not acidic. It is alkalotic. They are the exact opposite. Okay, so that is the simple explanation there. Now, if we are talking about the ME, okay, let's replace that one. ME, metabolic equal. So again, we need to have the values here. So for the pH, remember about the pH, if the value is less than 7.35, okay, what is that? It's acidic, right? Easy peasy. That's acidic. However, if we have a bicarbonate value of less than 22, okay, remember about the bicarbonate, which is basically an alkalinizing agent in the body. It's basic in nature. And if we lack the bicarbonate in the body, what would happen? It will become acidic, right? So with a low bicarbonate level, it is also acidic. Same thing with the pH, okay? So if we are gonna reverse that, let's talk about elevation of the pH and the bicarbonate. Let's take, for example, maybe greater than 7.45, which is the upper limit of the pH. Again, if it goes beyond the 7.45 or above it, that simply means that the blood is basic in nature. It's alkaline, okay? Now, if we are going to have an elevation of the bicarbonate, which is greater than 26 MEq, or if you have more than that, well, of course, you have lots of that alkalinizing agent. You have that basic blood. So again, you're going to have an alkalosis. So do you see the pattern here, guys? That whenever if both the pH go down, or if, let's say, they're going to go up at the same time, they're going to have to achieve the same acidity or alkalinity, right? So this is also alkalosis. Okay. Can I get a yes if you have understood about the Rome? Yeah? I think I'm losing people right now because I'm talking way too slow. But I'm just trying to explain here really slowly in order for you to capture the fundamental concept about the ABG. Okay, so that's about the Rome. Okay, so you need to have that reference range first. Okay, you don't have to guess. If you're just starting to learn, you don't have to guess the numbers. You have to look into the reference value so you can get used to it. All right, now further, when we have identified those leaning, either acidity or alkalinity, what we need to do here now is to make sure is to review the patient's values. Okay, we're going to have to review the patient's value. So focusing here on the pH right here, let me just put it here so we'll have enough space. pH of the patient is 7.27. So just by looking, what is this? Acidic or alkaline? Yeah, it's acidic. Let me just put here acid. And the PCO2 is 33. Okay, so according to the reference range that we have earlier, we are lacking the carbon dioxide. So it will be alkalotic. Okay, but before I get lost again, I get so distracted, guys. I'm sorry. So the first step here. Yes, that's true. Virtuous lady, thank you for helping out. So what is the first step in the interpretation of the ABG? What we're going to look for first is analyze the pH. That is the first thing that you need to do. Analyze the pH. So we have our patient's information. The pH is 7.27. Just by eyeing on it, yeah, acidic already. All right, analyze the pH, 7.27. We have an acidic blood. Okay. Now, the patient should have, oh, okay. So what we're going to do next here is to analyze the PaCO2. That's the second step. Looking into the patient's value is 33. This is very low, guys. Remember, if we have less than 35, your body is deficient of the carbon dioxide. It's leaning towards alkalosis. So 7 or the 33 mmHg is alkalotic. Now moving forwards, the next step here is to analyze the bicarbonate. Analyze HCO3. And what is the patient's value here, guys? It is what? 19. And the normal range is what? 22 to 26. And remember about the bicarbonate, which is an alkalinizing agent. It is basic in nature. And so if it is low, less than 22, then simply means it doesn't have that alkalinizing property anymore. It's no longer alkaline. So our patient's number is 19. So this is considered as acidic. Okay. So let's take a look. The patient's pH is acidic, 7.27, and the patient's bicarbonate is actually leaning to the same direction, which is acidic as well. Okay, so that's 19. So we are going to look for those lab values that go together. Okay, so which one is pairing here? Okay, so we have the pH, the blood pH, which is acidic, and also the bicarbonate that is also acidic. So this is how you're going to look for what lab values that are pairing, okay, or going towards the same direction, towards acidity, or maybe towards alkalinity. And we are finding here that both the pH and the bicarbonate are both acidic. It's the carbon dioxide that is the alkaline in this situation. Now, that interpretation is not done yet. We need to identify if there is compensation. Okay, so that is the next step here. We are going to interpret for the compensation. And the compensation can be varied as well. There could be a partial, there could be a complete, or there could be no compensation at all. C is no compensation. And I'm about to clear the slide right now. It's getting confusing for me as well. So how are we going to know if it's a partial compensation? Okay, how do we know if it's partially compensated? All right, let me get rid of some writing here so to accommodate space. Let me rewrite that because it's not readable anymore. I don't like it. I want to make sure we're going to have a fresh start. Okay, talking about the partial compensation. Partial C. So what is the criteria for having a partial compensation interpretation? Well, it needs to have all three values to be abnormal. Okay, remember this, guys. Make sure that all the pH, the PaCO2, and the bicarbonate are all abnormal. They are not in the normal range. Okay, if the patient has a complete compensation, then the pH should be normal. All right. If we are going to establish an interpretation of no compensation, then either the PaCO2 or could be the bicarbonate is normal, but the other lab value is abnormal. Okay, so for example, let's say for example, the patient's partial pressure is, let's say, I would probably put here 40 for the PaCO2, and the bicarbonate will be abnormal. Let's say maybe around 32, okay, something like that. So this is only going to give you a better idea to interpret now that, hey, there is now an imbalance of the three. So for example, the partial. So your criteria again, that all of the values, the pH will be abnormal, the bicarbonate will be abnormal. So there is what we call as instability in all three of those. There will be compensation, but again, they are what we call as partial because none of them is normal, okay? Now, if you're gonna talk about complete compensation, it's either that the bicarbonate is going upwards, which is going to be alkaline, and then the PCO2 will also go up, which is acidotic, but the pH is within the normal range. So there is what we call as complete compensation. So the PaCO2 and the bicarbonate will be either on the other side. The other one is acidic, the other one is alkalotic. However, in the no compensation, either of the two, the PaCO2 is normal, while the opposite one is abnormal, okay? Or normal, while the other one is abnormal. So now we're going to have to interpret here with the values that we got from this patient. So what do you think here is the diagnosis, guys, for this patient? Since we have an acidotic pH, and then the PaCO2 is 33, which is basically an alkalotic. It's going downwards. And then we have a bicarbonate of 19, which is acidotic. So what do you think about this diagnosis? This is going to be what? A metabolic acidosis. Why? Because the lab value that is going with the pH is the bicarbonate, which is basically gonna show us that the kidneys is the problem here. The problem is in the kidney itself. It's not able to produce the bicarbonate, enough bicarbonate into alkalinizing the blood, okay? So this is what we refer as the metabolic acidosis. So you have to identify that lab value that goes with the problem, the pH. Now we're going to have to identify here, is this going to be a partial or is this a full compensation? This is going to be a partial compensation because none of the lab values are normal. Okay, remember, we're going to state that it is going to be partially compensated if all of the values are out of whack. Okay, we're going to state that this is going to be a fully compensated imbalance if there is what? A normalization of the pH, and we don't see that yet in this scenario. Okay, so I hope that you're able to learn some concepts here. And again, I'm telling you, it's not something that you can learn just one setting. You have to refamiliarize. So we will be doing another ABGs in the next sessions. Okay, but we're gonna have to move forward. Partial all are not normal. Yes, partial compensation simply means that all of the lab values are out of whack. All of those are abnormal. The pH, when you're gonna say complete compensation, then the pH is normal. Okay, so this is what we call as partially compensated metabolic acidosis. So again, the problem, the primary source of the problem here is in the kidney. There is not enough production of the buffering system, the bicarbonate. And so the lungs is trying to what? Is trying to lower down its value by allowing it to what? Decrease its carbon dioxide. It's 33. So you're going to imagine this, that the patient is probably hyperventilating at this time. It's getting rid of the excess CO2 by elevating its respiratory rate. Okay, let's move forward here. What time is it? It's 2:42. Let me just have one more question and we'll move forward with the rest of them tomorrow. The last item here is question number 13. While assessing the patient's posterior chest and noting absent tactile fremitus, when the patient says 99, what should the nurse do next? Okay, question 13. While assessing the patient's posterior chest and noting absent tactile fremitus, when the patient says 99, what should the nurse do next? So this is a very basic nursing skill when you are doing the chest wall assessment. Okay, so what should you do? Is it going to be check the anterior chest for signs of burial chest? Or is it B, instruct the patient to perform turning, coughing, deep breathing? Or is it C, examine the chest x-ray for indications of pneumonia? Or is it D, listen to the breath sounds both in the front and back of the chest? This is very basic nursing skill that will often come out in the NCLEX. And don't you think that's kind of frustrating? That is a very simple procedure and you don't know it. It's just frustrating. So I really want you to go back to the fundamentals here. So I hope that you're answering this question now. So I'm reading the question on venous redaran. If it's uncompensated, what will be the values of the pH and CO2 and the bicarbonate? Okay, so we will go back to that in a minute, all right? Okay, so let's answer this question. What would be your answer here? Once there is absent tactile fremitus, what would you do? Okay, what would you do to the patient if you are, okay, do you still remember this assessment skills? You're going to have to bare the patient's chest. Make sure that you are exposing the patient's chest, and you're going to have to apply your both hands with, of course, the palms facing or touching the patient's chest wall. Let's say, for example, if the patient is facing against you, so you are putting your bare hands on the patient's skin, and you're going to have to instruct them to say 99, 99, 99. And when they are doing that, you're going to have to feel the vibrations in their chest wall, and then you're going to have to move your hands downwards to assess the vibration while they are saying 99, right? So this is what we call the assessment of tactile fremitus. But the issue here is there is now absent tactile fremitus. Well, if there is now absence of tactile fremitus, oh, your answers, let me see, B. You answered B as well. Instruct the patient to perform turning, coughing, and deep breathing. So guys, this is actually going into an intervention already. Okay, so we are still in the assessment phase. In order for us to investigate further, you have to proceed with the next step in your assessment. Remember in your assessment skill about the inspection, please don't forget your basics of nursing assessment. You start with the inspection. Next, you're going to have to do the palpation. And also, you're going to do the percussion. And then lastly, you're going to end up with the auscultation, right? Remember this? If you're auscultating, if you are doing the assessment, the chest, that is the IPPA. However, if you're doing the abdominal assessment, it's the other way around. It will be the inspection, auscultation, and then followed by the palpation, and then the percussion for the abdominal assessment. Percussion. So this is for abdominal assessment. Okay. So now that you have heard the patient, or you have felt that there is lack of vibration, because normally when you are doing the tactile fremitus testing, when the patient says 99, 99, 99, you should feel the vibration. Can you do that to yourself right now? 99. Can you do that? Like touching your chest, even without like it's exposing your chest. You can just touch your hand to your chest right there while you are saying 99. You could feel the vibration, right? That is normal. This is expected. However, if we are talking about absent tactile fremitus, that simply means that there is consolidation of percussion and palpation, rather. Yes. There is consolidation of the lung fluids. Okay. There is going to be that consolidation of maybe secretions, pulmonary secretions in a case of pneumonia. And what you're going to expect here is that you cannot really feel the vibration when they are saying 99. So in order for us to investigate further, you're going to have to go next, possibly to the percussion. But again, we are limited in the choices. So what would be the next step here? You're going to listen to the breath sounds, which is the auscultation part. Now, if you're going to listen, you probably will now be hearing the crackles, or could be diminished breath sounds because of the consolidation of the fluid in the airways, or maybe primarily coarse crackles. And so you're gonna make sure T could be the next assessment. Yes, because this is going to be a investigation to further note if this is going to be supported by your auscultation. So here we are limited only to the auscultation. We don't have the percussion. But if we do have the percussion, then we have to do the percussion first and followed by the auscultation. All right. So that will be the sequence in your assessment for the chest wall. All right. So if you have answered letter A, check the anterior chest for signs of barrel chest. that should have been done already before you have done the tactile firmness testing. So eliminate letter A. And if you had answered letter C, or letter B rather, instruct the patient to perform turning and coughing and deep breathing, we are not quite sure yet if the patient's lung fields are really caused by consolidation, right? And so we need to go through the assessment of the percussion to see if there is dullness or if there is hyperresonance. And then following that will be the auscultation to really detect if there is going to be consolidation of those fluids, let's say crackles, hoarse lung sounds, okay? So don't forget the very basic steps in the assessment, especially for the chest assessment. Okay, so I hope that you were able to capture those, guys. Okay, now the test taking strategy here really is to go back to your fundamentals of nursing, observe the sequence of your assessment techniques, okay, and make sure that you're going to eliminate those unrelated options. We don't really need to address the patient's problem right now. We don't have an information that says they are having shortness of breathing, they don't have an issue with oxygen saturation. We don't have that information in the scenario, okay? But if they could probably some more information, let's say hypoxemia, or let's say respirations that is kind of elevated, we don't have that, then our sequence here in the investigation will be all about the assessment first thing, okay? So that's pretty much it, okay? Palpation will last. This could be an assessment as the next step, auscultation. Serious palpation, not last. When you are actually doing the chest wall assessment, start with the inspection first, the observation, okay? And then the palpation, basically, just gently touching the areas, the anterior or the posterior chest wall, and then you're going to follow it with a percussion, and then lastly, the auscultation. All right. So I hope that you're able to learn from these session today. It's almost 3 hours past. So we will be resuming our discussion tomorrow with the remainders of the topics here, or the when you are talking about the abdominal assessment. Okay. So again, it will start with the visual inspection, and then it's going to go next to the auscultation, and then followed by the palpation and percussion. Okay. Palpation, then the percussion. Remember about that sequence when we are determining for the, what do you call this? Like the enlargement of the liver, it could be the spleen. Remember that we have to start with the less invasive procedure. So we're going to start with listening first in order not to disturb the peristaltic movements. And then we're going to have to proceed with the percussion, and then followed by the palpation. Yes, that's what we're trying to explain here. So inspection, then followed by the auscultation, then percussion, and then the palpation. All right. So that would be in that manner, IAPP, percussion and palpation. So I hope that you were able to gain some more insights from today's lecture. We will be proceeding with our discussion tomorrow. We still have a lot more. Yeah, so keep an eye out for some new announcement. But for tomorrow, we're going to have to deal with other concepts here. There's still some more that I need to go through with the TB, as far as this diagnostic testing, the interpretation of the Munto testing. And so I really appreciate your participation. I really do. And so I really expect that you're going to be here again tomorrow, same time at 9 p.m. Eastern time. And again, please don't hesitate to post your comments and your questions. If you need to clarify things, please do that as well. And again, I'll see you tomorrow at 9 p.m. I am grateful for your participation. All right, take care, everyone. Bye-bye.